Oh, thank you, Matt. So, yeah, and a long but very, very generous introduction. Thank you. I think the most important reason why we're all here is that we are both passionate about improving the quality of care in nursing homes, and we have realized some of the uncovering of crises that this public health emergency has brought forward, but also some new opportunities and flexibilities. And that's really what I'm here to talk about today, and that is the focus of telehealth in the time of COVID. Now, I am not pretending to be a technical wizard. In fact, you could ask me just about any tech question and I would defer it. But the reason why I'm excited about being part of this conversation is not only the clinical work in the nursing home setting, but now my work in advocacy and public policy and understanding some of the intent of the flexibilities that the Centers for Medicare and Medicaid Services, affectionately known as CMS, has brought forward to us. And really the important thing is to relate to all of you how you can use telehealth as a tool to address those needs for the individuals that you are serving. Have no financial interests or conflicts of interest to disclose. And this is just real briefly what our learning objectives will be. We want to look at the expansion of telehealth during COVID. I want to talk about the role and opportunity of telehealth to better serve individuals in post-acute and long-term care settings. We want to look at some of the challenges because everything is not nirvana. And I know many of you who have tried to implement telehealth will be the first to send me a text and say, yeah, but. So we're going to talk about some of those challenges. And then I want to get through some resources. We're not going to go through all the steps for telehealth implementation. That would take probably 2 more sessions, but there are some wonderful resources out there. So as we jump in very briefly, what is the SNP Alliance? I made reference to it. Think about the SNP Alliance as an association for specialized Medicare health plans, managed care Medicare health plans for high-risk, vulnerable, older adults. And if you want more information on the SNP Alliance, our website is available in the chat box. So telehealth and COVID-19, woohoo. First of all, telehealth and the idea of nursing home settings is not new. This has been a conversation that's been going on, I would say, at least for the last couple of years. But there were lots of limitations. We all know those. There were lots of challenges about who did what and who had authority and how do you bill and then came the public health emergency. Effective March 6th, a myriad of flexibilities were brought forth under the public health emergency through CMS. This included using the 1135 waiver authority, which allowed for 53 separate waivers. Now, I'm going to caution all of you that remember at your state level, there are different requirements for scope of practice and licensure. So do be aware of your state regs related to telehealth. But the important thing is it now applies to all areas of the country. There weren't just rural or separate demographic environments, but all areas of the country. Nursing homes do not need a waiver. You don't need to do a separate application. But the expectation of CMS is that nursing home staff will need to facilitate the experience by managing the technology. So we will talk about that in a little bit later. Telehealth waivers now include any health facility or the individual's home. There have been lots of questions about HIPAA penalties and privacy. CMS has waived those penalties, but they do encourage good faith privacy precautions because we know that many of the devices being used are not HIPAA compliant. And while initially it required audio and visual connections, qualified providers may use and bill for audio only, and they may retro bill back to March 6th. So those are some general concepts. This is a very busy table, and we're not going to read it all, but it outlines when CMS is talking about telehealth, what are they meaning? And there are generally 3 kinds of visits: Medicare telehealth visits. It is important to know that Medicare telehealth visits have now expanded. So it's not only what are previously considered the Medicare authorized providers for billing, but but it also allows now for physical therapists, occupational therapists, and speech therapists to utilize telehealth visits. I'll be sending a reference out at the end about the billing for this. There's also the opportunity in a separate code for established patients for a virtual check-in. Therapists may also use this virtual check-in as well as physician and non-physician providers. And then the e-visits having to do for established patients, and there's a separate criteria of coding for the E&M codes for e-visits. This link below will give you a wonderful set of resources that can give you some of the details about the billing. So let's look at something specific for nursing home settings. It does require that the patient has a relationship with a provider and or practice. There is not a requirement, but an encouragement for patient or resident consent. AHRQ has a wonderful resource that I've included here for sample consent forms. There is a specific correct location site for nursing home billing. And all of these things with lots of detail are in this link that I have included and are also on the chat box that has to do with a nursing home telehealth toolkit that CMS has created specifically for the nursing home setting. Here's some language looking at the proposed fee schedule that came out a couple of weeks ago. It's awaiting for comment, but the reason why I include that is that there are separate issues that, or several issues that I think have real pertinence to this discussion, and also the opportunity for many of you to provide comment. So two particular areas that I wanted to address. The public health emergency, CMS waived the requirement for physicians and non-physicians to do required visits for nursing homes and allowed these visits to be conducted via telehealth. So CMS is seeking comment on whether or not it would be appropriate to maintain this flexibility. I think there are a number of arguments, particularly in rural communities where providers are not readily accessible. I've spoken to a number of nursing homes that used to take the ambulance from the little town and transport the individual an hour away to get the required regulatory visit. These would be very appropriate for telehealth assessments. So the question is whether or not we should continue this flexibility. And then the subsequent visits, there were some limitations initially about acute care or inpatient visits, and also follow-up nursing home visits. Originally, you could only do a telehealth visit once every 30 days. In the new proposed fee schedule, CMS is proposing to revise the telehealth frequency from one visit every 30 days to one visit every 3 days. It is currently allowed under the public health emergency to have the more frequent visits. What the question is should they continue that flexibility going forward? So who pays for it? Boy, gosh, it is never as simple as it looks, right? The Medicare fee-for-service provider payment schedule proposed rule includes the specific payments for telehealth services. And right now, the proposal is parity for in-person services. Many managed care organizations that are working in nursing homes, however, may have very different contract relationships, particularly institutional or I-SNPs, institutional special needs plans. Some of these I-SNPs, for example, have paid for devices to go to all of their residents who are in their I-SNP plan. They have also included payments above and beyond the professional services for provider services, unless of course they have contracted relationships. They've also done, in some situations, nursing home supplemental payments for the additional nursing home required for telehealth. These are not mandated by CMS, and they are all under different relationships. However, these same managed care organizations are also having some concerns about payment parity with fee-for-service. And so as you go forward, it's important to look to your managed care contracts about payment for telehealth visits, particularly on the provider side. Some areas that we have yet to have clarity on the impact for documentation. How does a telehealth visit fit into the requirements for documentation? How do you transfer that information, for instance, to the nursing home medical record? How do you capture HCC scores? For those of you who don't speak managed care, the hierarchical of chronic conditions, those are the list of diagnoses or conditions that weight the risk of payment. It's less important on the fee-for-service side. It's very important on the managed care side. How do you capture these scores if you are using telehealth and don't have written documentation? And then when CMS does health plan audits to make sure that people are in fact documenting everything to match what their reported risk adjustment scores are, how do you capture all this information? What about audio only? How do you take this documentation? So there's a lot. I bring this forward because I suspect there will be questions about these and we don't yet have the answers. So for example, how does the physician or nurse practitioner or PA assessment get captured into the MDS through telehealth? These areas are not yet clarified. Very briefly, home health and telehealth. So in this same document I have included down below from July 9, it has some good recommendations for home health settings. Now on the home health claim, only in-person visits can be reported, but there are some additional waivers, not only for the follow-up visits as long as it's in the plan of care, but also for some quality reporting data and aid training, managing appeals, etc., mechanisms for using telehealth instead of in-person visits. And these are all included in this resource I've listed. So we know that telehealth provides some amazing solutions. I mean, and we'll go through them, but I think all of you can add to the list. Certainly the ability to meet with patients, residents in nursing home settings, but CMS uses the terminology patients in a more broader sense, without risking physical contact. And in a time of a public health emergency for infection, this is also very important. It also provides solutions to transportation challenges, particularly for individuals who may not be able to get to certain types of providers and yet still need assessment and interaction with those healthcare providers. It allows the ability to do timely assessments. So you have a change of condition after hours, the nurse practitioner has left, and the family's concerned about whether or not their loved one needs to be seen. Why would the only option be an emergency room transfer, particularly in a time of public health emergency? Telehealth allows that opportunity to do timely assessments and also to provide follow-up to acute illnesses without requiring a person be moved, transferred, go to the emergency room, or be seen in another setting. And as I mentioned earlier, it allows the ability for regulatory assessments and routine assessments, particularly in a time where the nursing home communities are trying to restrict outside visitors or individuals because of infection control, particularly if it is a nursing home community that has already an impact of COVID-19 and is following strict isolation. And I think one area that probably hasn't been leveraged enough but has some of its own challenges is the ability for family and residents in nursing homes and assisted living to be connected with loved ones and friends and family when in-person visits are not allowed. But there's a challenge. So looking at the potential limitations of telehealth. First of all, you need to appreciate what are some of your state regulations and some of the interstate licensure challenges, particularly that relate to scope of practice from one state to another and how those transfer. You need to, and this is coming from a clinician's perspective, I am concerned that there are times when we actually need in-person evaluations. Is there a true sense of urgency? Can we truly do the full scope of exam via telehealth without seeing the person? Is telehealth an adequate substitute for all interactions with vulnerable older adults who may have limitations in being able to engage in the conversation to relate their symptoms. So I'm still thinking that we as clinicians and as professionals in nursing homes, post-acute and long-term care settings, I think we need to start thinking about how do we determine when an in-person visit is required, or do we just default? I would be concerned if all of our visits automatically became telehealth visits. Nobody is arguing for that, I realize that, but when do we move forward with in-person? There's a lot of concerns about lack of privacy, and that has to do sometimes with the resident and or the family who's concerned about having third parties who are managing the telehealth. And we just need to be aware and cognizant of it. There's limited access to technological devices, frankly, or lack of comfort with such. Not only with the individuals that we may be serving, the older adults and or their families, but I would also offer the staff. So merely giving nursing homes a bunch of devices doesn't mean that we have a functional telehealth platform in place. We also need to be extremely cognizant. I was from an era, and many of you on this session are probably way too young to remember pre-EHRs or EMRs, electronic health records. But I remember in the early 2000s when we healthcare professionals were told, oh, it's going to make your life so much easier, and it's going to save so much time, and it's going to be so seamless. And we all know 20 years later, that is not the truth. There's huge value in EHRs and EMRs, but the argument that it automatically saved time, it created different time. It created different information loads, and it created different workforce challenges. The same thing is happening in nursing homes. To just assume that a nursing home that is already challenged with staff needs, already is having problems perhaps with staff out on administrative leave for COVID exposure, or perhaps ill, or other staff who are frankly fearful of working in the setting. They're already scrambling to meet their staffing needs. And now you throw a telehealth device, realizing that you can't just assume that the resident and the provider are going to be able to have this telehealth visit without support and supervision by the staff member. This is creating a whole different level of workflow needs that we have to be very cognizant of. And I don't want to minimize the impact also on direct care. Many of the device interactions, particularly with family and residents, are being managed through direct care workers who are also trying to serve the needs of all the other residents within their scope of care. And so as we think about implementation, a strong cognizant awareness of how are we supporting the staff, not only with training, but with adequate staff and their resources in being able to manage this new technology. So implementing telehealth, it takes a plan. There is a wonderful outline of resources. It comes from West Health, and it's now included on the chat box. This actually predates COVID, but it is a wonderful, thoughtful, organized approach to how do I think about implementing telehealth in my post-acute or long-term care setting, because buying a bunch of equipment is not it. So thinking about and it goes through each of these strategies. We won't go in a lot of detail, but begin with the needs and the readiness assessment. Why are you doing this? What's driving this? What's your needed technical infrastructure? What's your timeline and budget? Who's paying for it? Is this a partnership with other payers? Is it the nursing home community? Is it the acute care? How are you looking at this? Who's paying for what? How are you looking at the return on investment, or ROI, as we've all become to know? Because it's more than just decreasing acute care utilization. It may have impact on your quality, it should. There should be improved marketing and marketing impact within your area. It should have an improvement and impact on your stars. So what kinds of vendors, payers, and provider contracts are you setting up? Do you know how the workflows, including the workflow for your staff, as we just talked about? What are some new potential licensing and credentialing requirements, particularly if you are using providers who are out of state, and the licensing for some of the devices? So this telehealth guide will walk you through all of these things. Of course, you can't forget the lawyer stuff and the policy stuff, but then you also need to think about how do you maintain the performance and the stability. We've all been in scenarios where the new technology is rolled out. It is an infatuation, and then it's put aside because people don't use it, or things break, or they don't know what to do to solve a problem, and then you just go back to the old working way. How do you manage these? So I encourage you to use this telehealth resource as a remarkable tool. There's also in some resources that I will post at the end, some additional resources on understanding telehealth and its implications in nursing homes. Let's talk a little bit about some of the advocacy. What should we do to make public health emergency flexibilities permanent? So we are supporting the expanded types of healthcare professionals within scope of practice to include therapy providers. We're expanding and requesting the continued elimination of site requirements to at least include home care services. You can read all of these. I won't read them all for you, but we know that it's going to be hard to put the toothpaste back in the tube. And because we have these flexibilities now, and we're demonstrating that good care can be delivered, part of the advocacy challenge is going to be to move this forward. So as I wrap up, these are some additional resources. There is one, I think it's the third bullet down on paltc.org. That's the AMDA resource. On that page, you will actually find 2 pages of links that cover everything from payment to legal issues to implementation. There's a lot of resources built in here that I think will answer many of your operational questions. And with that, I'm going to close up. Here is my contact information, and you are very welcome to send me email questions. Thank you very much.